Here with a very distinguished panel and very excited to open a live case session on left atrial appendage occlusion. So it looks like we are ready to go live to FUWAI Hospital. And hello, Dr. Feldman here, Dr. Park?
Yes.
So can you tell us about your patient and the procedure you're planning?
So, can you see us?
We see you and we hear you.
Okay. On my right side, Professor
Yao.
Professor Yao.
Yao.
And on this side, Dr. Tin. Yes. And Dr. Tin will introduce the patient.
Okay. Let me do it. Okay. This is a 73 years old female and with a persistent HFF. And she has also diabetes, mellitus, and hypertension, and coronary heart disease. And she came to for a solution, not specifically for the ablation. So after evaluation in my hospital, we decide he has a high risk for stroke. So she would like to try this appendage closure. The way we do this is Dr. Park actually, he wants to show the unique advantage of this series of LAmbre, which can use it for transeptal puncture also, but which require the general anesthesia. Unfortunately, my hospital is too busy, and we usually perform such a left appendage closure for without a general anesthesia. So we just do it with this lidocaine injection locally. So we cannot perform that way. So we use our decapolar catheter placed into the coronary sinus for anatomic mark. So we develop our own simplified transeptal approach. So Dr. Dean just finished it without TEE guidance, just totally rely on the flow rule and this mark of the coronary catheter. We finish this transeptal. Usually we can finish this with 1 minute. So Dr. Dean finished that. Then we just replaced with this LAmbre C systems. And then now we just finished the measurement of this left appendage. Both rejection, Dr. Park.
Yes, so we have done 2 angiograms, one in areal 30 caudal 20, and the second angiogram in areal 30 cranial 20. And we have the measurement of 24 millimeter at the orifice, and the depth is long enough. And in the other plane, we have 23. So the bigger one is 24 millimeter at the orifice, and this is very similar to the measurement of preoperative TEE yesterday, which the largest diameter in the short axis was 23 millimeter. So the special beauty of the LAmbre system from Lifetech in Shenzhen, the Chinese product, is they have a variety of different sizes which differ in between the so-called umbrella, which is the fixation part, in comparison with the disc, which is close the orifice and seal the orifice. And therefore, we have a total number of 17 different sizes. So in particular, if you have a cactus-like appendage, where you have in the fixation part only small and narrow space, you can choose a smaller umbrella and combine this with bigger disc. This is one of the major limitations in complicated LAA anatomy for Watchman or for ACP or Amulet from St. Jude. So we have the maximal diameter of the orifice of 24 millimeter. And if you look on the list, can you see the list on the screen?
Yes, we see it.
Yes. Then so the next slide, the following part of the list. the list.
前一个那个幻灯，
So I have here the list. This is,
下一张幻灯，
We see 11 to 20.
yeah. So here is the higher number missing. So we will choose 2834. 28 is the size of the umbrella. 28 is an oversizing over the highest diameter of the orifice of 24 or 4 millimeter.
Jae-woon, can we see the device? We see only the chart now.
We don't have packed out the device, so we will pack out now the device. Please,
What's that,
2834.
28
2834.
28 28 34
So you are oversizing by 4 millimeters, right?
Yeah. So normally it's depends on the space behind the neck. And
Can you show us on the screen where you measured?
just at the orifice, we only measured the orifice. And behind the orifice, there seems to be enough space.
You had an angiogram looping a minute ago that showed the measurement. Yeah, here we go. Very good.
Do you see the measurement?
But that's 22.6, right?
Yes. This is the other thing. Show the next scene.
干数的下一个，
So this is 24.
再往里面
This is the caudal view.
So you pick the largest, you pick the largest diameter on the
Right.
angiogram and then oversize by 4?
Oversize by 4 to 6 or 3 to 6. It depends on the space behind the orifice. So you see here that we have introduced a 10 French delivery sheet, double curved, which you can use for all 17 sizes. Here now I pack out the LAmbre 2834.
Jae-woon, while you were doing this, when was the TE be performed in this patient? How-
Yesterday.
Yesterday, okay. Can we see a close-up of the device, please?
Yeah.
So Horst, are you asking about the timing of the TEE in reference to concern about atrial thrombi?
Yeah, that's why I'm asking, yeah. But I think a day is reasonable. That's also the time we would do cardioconversion if a patient shows up with atrial fibrillation, and we are not concerned then about thrombus formation, right?
I think I completely agree that it's reasonable, and at the same time that once in a while we do see thrombi form in that short period, and that's one of the advantages of having either TEE or intracardiac echo during the deployment procedure.
Yeah, that's why we do it during the procedure, but this probably depends upon the logistics in the different cath labs. Sometimes it is difficult to get the echo people in.
Flash.
Jae-woon, we see you, your back actually,
Okay.
but don't see the device.
Hold this. We have merged the device and the delivery, the loading catheter, the short loading catheter into the water, and I aspirate now and flash and one more aspirate.
Before you finish loading, could you show us the device? I think most
Yeah.
of us are not so familiar with this one.
Please push it out again.
Okay.
He has already loaded it, but we
So,
didn't see it.
Please show the device.
And also show us the different hooks which are there. I think that's important.
Here,
Closer, camera closer,
We
please.
zoom closer.
Zoom,
Yeah.
zoom, 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 zoom,
Zoom more.
zoom. More.
you can see.
You can move it here.
Barely. keep it still. Don't move around.
Closer to the camera.
Show,
Yeah.
Better?
zoom in and keep it still.
Yeah.
Okay, and turn it
That's
around so we
better.
can see it from the side.
Yeah.
Okay, and focus. Okay, can you show us the different type of hooks which are there? But don't move the device, because otherwise the cameraman cannot follow.
你再靠近一点，你看要看这个细节，
Ah, getting better.
再大点，再拉近一点。哦，对对对，再拉近。
Okay. So now when you now, oh, that's very good. Now keep it still and then pull it back into the sheath or in the loading tool and show us how it comes out, because that's an important difference to all the other devices.
Right. It's just like an umbrella. You see here?
Yes.
It is rolled out.
Yeah. And these big hooks are actually not designed to get into the wall. They are just,
Right.
well, they will also prevent embolization, but actually the small hooks which come out now, keep it still.
Yes.
The small hooks are designed to engage the
Yeah,
wall.
here are now the hooks, the small hooks in parallel. Now are the small hooks, and if I push and roll out,
So the hooks are so small we cannot see them. So the big hooks you see, these are the hooks which are not, no, we see them. Okay, good.
Yeah.
Very small, 1 millimeter long,
Yes.
right? Mhm. Okay.
the big hooks are bended, so this is automatic. You can again see the big hooks at the far distal, and this is bended.
And as Dr. Park will show during the deployment, so it's important not to open the umbrella deep inside of the appendage,
Right,
but in
right,
order to avoid,
okay.
these big hooks should not get into the wall. That's important.
So now we de-air. Can you come here? Can you come here?
I think for most people closing appendage, they would choose an occluder that usually would stand against the
Hold.
appendage wall based on the measurements.
And
But for this
close,
device, the big
close,
hooks
close.
actually was designed to be trapped in the
Wait a moment. We have to
pectinate
clear
muscle. So even in this
This is-
case, although he chose 28, I think even with 26, the device is very stable. So you don't really need to choose a device that stands against the wall. The measurements that Jai-Woon did is actually an arbitrary line. The umbrella should be positioned
Water.
actually distal to that line instead of at that line level.
now aspirate,
你等它锁上再冲。
aspirate, aspirate.
Kathleen, has ever one of these devices embolized?
No, no. In no case. So we have an overview. All cases done in human until now is within studies. So therefore, we have a 100% follow-up, missing no patient. And this is meanwhile more than 260 cases and no single embolization reported so far.
大家跟
So let's move.
What is also nice with this device that it requires only a 10 French sheath, which is sounds trivial, but the big sheath with the other devices are sometimes a hassle to get them into the groin and also transeptally.
So can you?
Yeah, I
The
think the beauty
bigger
of
concern I
10
have with
French
the
sheath
sheath
is that
caliber
you
is
can use this sheath
manipulating it in the
directly.
appendage.
Say again?
Manipulating the larger sheaths in the appendage. The groin is not so important, but having a smaller profile.
Yeah, that's absolutely true, but even to get them through the groin sometimes is, as you know, sometimes difficult, and sometimes the wire then bends and so on, in unexperienced hands at least, like myself.
And because the size of the sheath is quite small, 10 French, you can actually put in a needle and use this sheath as a direct septal puncture sheath. So you don't really need an additional set of puncture system. So theoretically, if you use this sheath for puncture, then you can shorten the
flushing
duration
it,
of
no?
procedure to around 25 to 30 minutes.
Kathleen, do you also do this without echo?
Yes, I did it mostly nowadays just local anesthesia without echo.
So now I'm advancing the device through the delivery sheet. As you can see here, I have the high pressure flush, and under high pressure flush to avoid air embolism, I advance.
You use the decapolar catheter as a reference for transeptal. Does it also help you for positioning the device?
Yeah, sure. So now I am with the distal part of the device of the umbrella at the second marker. You can see here. This is now in the distal marker, and you see the connection between the umbrella and the folded disc in between this thick marker. And now we have here on this side the delivery cable. I can pull back, you see, the delivery cable is still attached to the device. So now I will deploy. For deployment, I change the plane to Arial 30, quarter 20. Again, 20. Okay. Dr. Yao, can you give die?
Would it be possible? Yeah, okay.
Okay.
Thank you.
So see, in doing this procedure, you don't need to deep seat the delivery catheter. You just put the catheter tip at the opening of the appendage, and then you push out the umbrella. And there's 2 marks on the distal part of delivery system that's used for calibration. It's around 10 millimeter. So Horst just mentioned we can actually do this entirely under local, because if you're familiar with transeptal puncture, that's okay, because the demand on the exact puncture site is less with this device, because you don't have to deep seat the delivery catheter. And then, of course, TE can help you to check the stability and also the leak after implant, which I think Jarwin will show you. We don't need really TE information also on these 2 aspects.
Yeah.
It's pretty close to the roof now. I would not advance it there.
The,
Maybe counterclockwise rotation may bring it down.
yeah, but the catheter don't turn. I try to clockwise rotate.
Jarwin, another way is don't push the catheter. You partially open the device here, then you will fall down a bit due to gravity, and then you can gradually push in the device.
You are
now
really
you
pushing
see-
hard
yes.
to the wall, huh?
Yeah, that's
Okay.
that's about right.
The most important point is that you have to fully open the umbrella until this point.
Can you give a little puff of contrast now?
Yes. Contrast? Contrast? Okay. So, Horst and YY, what do you think?
Looks better now.
Yeah, it looks great. It looks great.
Good position?
Good position.
Yeah.
So now I unsheath the catheter, unsheath the device, and push out the disc. Okay. So, angel. Excellent. So what I'm doing now is turning the scene and trying to bring the disc very parallel and the umbrella very parallel. Because now the so-called early remodeling happens. Because if I deploy the device, the disc, the appendage, which is normally anteriorly rotated, turns anterior to his original position, which was, before I deployed the disc, stretched. And so I can early estimate how strong the rotation of the appendage body is behind the neck. So this is not that much rotated. Now I do a second angio control. So I'm happy. So So normally for LAmbre, you don't need to do a vigorous tuck test, but
You can do.
I can do
I'm
here.
sure it will be there.
So I go back, and so this is now a so-called modified tuck test of continuous tuck.
Do you have any concern about covering a pulmonary vein with this large a disc?
Pulmonary vein. So I have a lot of experience with ACP. I have never seen a real problem. The mechanism of the disc or in LAmbre is very similar of that of St. Jude products. So I have now done a continuous tuck. I think this is stable enough. Do you agree?
Yes.
Yes.
Okay.
So you see, for this device, stability can be checked by tuck test, and usually with a cover design, the leak is not really a major concern. So that's why, again, you don't need TE to tell you whether this is stable or is there any leak. For the question mentioned by that there's a chance of pulmonary vein obstruction or mitral valve impingement, you can actually do an angiogram to assess this information. You can do RAO view, projection, you give contrast, and then you will allow you to appreciate where's the pulmonary vein orifice and where is the mitral valve leaflet insertion site. It can also give you this bit of information. But as Jai-Woon said, normally you don't need to assess that because based on the experience that we have more than 260 cases, there's no single chance of really covering the pulmonary vein os and also encroaching on the mitral valve.
So if the podium is okay, I would now release the device.
Okay, we're going to apply the TEE soon, but the part decided to release the device before that. However, we still need to confirm that.
So for the release, I just slightly pull back and hold with my left hand. Can you show here? Here, my hand. Hold with my left hand, with the thumb and the second finger, the cable, so that I control the cable. Otherwise, if you lose the control of the cable, the cable tip may advance distally and get attached to the meshes of the device. And therefore, I just pull a little bit, hold with left hand the cable, and now I release. Yeah. And this is the second early remodeling. In the moment of release of the device, very often the three-dimensional constellation changes because having lost the contact of the delivery cable, the appendage snaps back to his anatomical position. Now finally I give one more contrast and control angio. I think I am happy with the result.
Looks very good.
Yeah. Okay. So no problem with the left superior pulmonary vein in this case, and no contrast flow under the disc. So I think
now we have our TEE.
now we have TE.
Why TE now?
Yeah.
You're finished. Looks good.
Yeah.
Usually we just confirm with TEE, then we just release it.
We thought you don't have TE in the cath lab. So
Yeah, but this time it seems that according to the contract.
You see the TE.
Yeah,
Yep.
you see TEE.
So a beautiful result.
Can you bring the color here?
Yeah.
小王，你往肺静脉那边转一转，看来没把肺静脉堵住，他们有些担心那个。
I like the result, but the pulmonary ridge is not really covered. I mean, I like it, but
I'm
it's
asking him to, yeah.
it's different from what you do otherwise, right?
Yeah, but the pouch is not that pronounced.
Agree.
And therefore, I think this is a good result.
You know,
Good.
Congratulations.
So thank you.
thank you.
Very nicely
Well done.
done.
Yeah, in time.